So we're going to go quickly a little bit about what supervised exercise therapy means for patient outcomes, and then just a little bit about how the reimbursement has changed in the last couple of years. So walking exercise is the most effective non-invasive therapy for improving maximal and pain-free walking distance in people with lower extremity disease. And this has been shown to improve both pain-free and maximal walking distance. Most randomized trials have just looked at supervised treadmill exercise. So if we go back and visit a little bit of the physiology of exercise, at the bottom we'll see that during rest the cardiac output is about 5 liters per minute, and the blood distribution is pretty even as far as to the stomach and to the muscle, with the resting muscle blood flow about 0.75 liters per minute. However, during heavy exercise, the cardiac output increases to about 20 liters per minute, and we see that most of that blood flow goes to the skeletal muscle, at which point the muscle blood flow increases to about 20 liters per minute. When we look at what happens at the artery level, we see that there's laminar flow, there's vasodilation by the endothelial cells that is normal, and we see that we have preserved O2, oxygen supply and demand, and efficient oxidation. However, when we looked at the peripheral, the arteries that are diseased, we see that during the high stenosis, there's high resistance, which increases turbulent flow, and the pressure drops. There's also endothelial impairment, and so we see that there's a mismatch in the oxygen supply and demand, and there's inefficient oxidation. And so what we want to do by doing treadmill stress exercise is to try to improve some of that, some of those outcomes. So there's a wide range of responses that have been reported for treadmill exercise training. Here was an example where we see that even at 12 weeks, we had an improvement in the claudication onset distance, as well as in the peak walking distance. And we can see that this actually improves once you go further in the therapy with 24 to 52 weeks. When they looked at several studies, in 3 studies, they saw that there was an increase in pain-free walking distance of up to 110%, an increase in peak walking distance. There was no increase in inflammatory markers. The erythrocyte deformability was significantly improved, and most importantly was that there was no improvement in the control group. So all these changes were just in the supervised exercise therapy group. The 4th study that they looked at showed that there were 2 different traditional walking protocols. In the traditional walking protocol, where you walk till you have moderate to severe discomfort, versus a traditional program, versus a treadmill program, where you had either just walking until the onset of claudication. Neither of these groups had any statistical difference from each other, although they both had statistical improvement in the walking distance. In a meta-analysis of 25 randomized clinical trials for over 1,000 patients, they were randomized to either supervised walking exercise or a control group without exercise. And what the results showed that was supervised exercise improved the maximal treadmill walking distance by 180 meters and the pain-free walking distance by 128 meters relative to the control group. Of the 21 trials that showed, 71% reported more than a 15% improvement in these markers, and 21% reported more than 100% improvement in the maximal treadmill walking distance. Among the control groups, only 1 reported more than 50% improvement, and none of the groups reported any more than 100% improvement. When you look at other different modalities of exercise, such as lower extremity cycling, again, you can see that the peak walking distance improves. You can see that the claudication onset distance improves. This was also correlated with a change in the treadmill training. So again, it's not just limited to treadmill exercise, but any kind of exercise training. When they looked at the aerobic upper body exercise therapy, using arm ergonometry, they showed again that there was a 50% improvement in the pain-free walking distance and 30% in the maximal walking distance. In the randomized control pilot study to determine the relative efficacy of 12 weeks of 3 times a week of supervised treadmill training or arm ergometry alone, we see that the claudication onset distance after 12 weeks was improved in both arms. We see that the peak walking distance was improved in both arms. And again, there was no improvement in the control studies. When you look at comparing supervised exercise versus iliac artery stenting, you see that there's no statistical difference between the peak walking time at 6 months or 18 months, and again, there's no difference in the claudication onset time in the supervised exercise training versus the stenting protocols. So when you look at how much it costs to make a difference, you see that it's $24,000 would make a difference between the supervised exercise versus optimal medical care. You see that there's $41,000 that would be spent to make a difference between a stent and optimized medical care, and you see that there's almost $122,000 that would have to be made, that would be adjusted to make a difference between stents and supervised exercise training. So what this has led is that there is a big push to have a recommendation for supervised exercise rehabilitation. We see that these are class 1 recommendations for having a discussion with the patients as well as having them enrolled in a supervised exercise therapy program. The program doesn't have to be anything significant. It can be in a standalone or within a cardiac rehabilitation program. It can be in a hospital or outpatient facility, as long as you have intermittent walking exercise as a treatment modality. It's recommended that you have a minimum of 30 to 45-minute sessions, and they're performed 3 times a week for a minimum of 12 weeks. So the biggest difference occurred in 2018 when CMS decided to reimburse for supervised exercise training for intermittent claudication. So they will pay up to 36 sessions over a 3-week period. That's 3 times a week. The following must be met. The sessions must last 30 to 60 minutes. They conducted either in a hospital outpatient setting or in the physician's office. They be delivered by qualified auxiliary personnel, and then they under the direct supervision of either a physician, a physician assistant, nurse practitioner, or a clinical nurse specialist. The CPT code is above. The payment for on-campus hospital outpatient setting is $55 per session, and then there's the different ICD-10 codes under which they can be billed. The elements needed to develop this program is just to identify a medical director, establish a referral process making the providers aware of the availability of supervised exercise training, and then training the cardiac rehabilitation staff on how to implement the program. Again, a baseline assessment using graded exercise test, a 6-minute walking test, and then using subjective assessments such as the quality impairment questionnaire and quality of life. Treadmill walking exercise is considered the gold standard for exercise therapy. Initial prescription based on speed and grade of the treadmill. The patients must be able to walk at least for 2 minutes. We determine the baseline functional testing, and then the training sessions consist of intermittent bouts of walking, resting based on claudication level, and using a claudication scale. So the claudication scale is the patients have no pain with an increase in how much pain they have. You want the patients to be walking up to the grade 3 or 4 where they have moderate pain. At this point, you need to stop before they develop severe pain. So you begin at initial speeds or grades that bring on the claudication within 2 to 5 minutes. You make progressive increases in the walking time. You stop and sit when they get moderate intensity pain. You resume when the patient pain has subsided, and you can continuously repeat this process for 30 to 60 minutes. And there are other alternatives to treadmill, but treadmill should be tried first. If they're not able to try treadmill, then you can try seated aerobic arm exercise or recumbent total body stepping. Obviously, safety considerations, unmasking any new angina, which may need further workup of cardiac disease, or any abrupt increase in the claudication symptoms, which could point to the worsening of lower extremity arterial disease. Thank you.